Hello everyone, Happy New Year. I'm Jenny from Education Team at Medit. Nice to meet you everyone. And as you can see, we have a special guest today from London. Please welcome Dr. Grisha Murgai.
Hi, everybody. Thank you very much for joining us. And as Jenny said, Happy New Year.
Yeah, thank you for joining us today. It's very late night from your side, right?
It's reasonably late. It is just after 11 p.m. here in the UK, yes.
Yeah, thank you for making the effort to record together.
My pleasure. Thank you.
Yeah, so let's talk about this topic. So it's about implant
Mhm.
journey with Medit. So what have you got today?
Yeah, it is. It's a little bit of a special journey. So when we were talking about doing a webinar, I was thinking that there were several different cases, but this is a special one because this patient on the same site on the lower left six site had multiple treatments. And in all of those treatments, I used the Medit scanner. So first I used it to restore his natural tooth. That lasted a few years. We knew it didn't have a great prognosis, but he wanted to make it last as long as possible, so we helped him with that. Later on, when the tooth failed completely and couldn't be restored, we used it for the implant planning part of the case. And then finally, we used it for the implant restorative stage. And I thought this was great because I could show you many different things in one patient with one scanner, and using all of the different tricks that I have in the box, in the Medit box. So, yeah, I hope you and the audience enjoy the content.
It seems really interesting.
Yeah, it
Okay.
kind of brings through restorative implant planning, implant restoration, but it's got my spin on it. So it's a reasonably straightforward case, but the content, I hope, will spark a few different thought processes in people out there who may be restoring implants already. Maybe they're doing surgery without using guided techniques. So hopefully, I've kind of touched on a few different things to make people think, and also have them have more reasons to pick up their Medit scanner for every different type of case.
Wow. Okay. So, do you often use surgical guide when you're planning for implant?
Yes, for my own cases, I'd say 95% of my cases these days are guided cases.
Oh.
But also in the laboratory that I own, a lot of the work that comes through to our laboratory is either implant planning or implant restorative. So we have designed and produced a lab over the last 10 years, which I'd say 80% of our client base is all implant surgeons. We do a fair amount of restorative as well, but yeah, a lot of it is implant based. So
Mm.
yes, we get a lot of cases like that.
Yeah, that seems really interesting. So we hope we learn as much as we can from you.
I hope so. I mean, I'm here to share. So I put my contact details at the end of the content, and happy to speak to people, whether they are existing Medit users or if they're looking to get into using a scanner and they're thinking, well, maybe Medit's the one to go with. What I've tried to do, Jenny, is I've tried to highlight in the content not just the hardware of the scanner, but primarily the software elements and what you can do easily with the Medit scanner that you simply can't do with many of the others which are out there.
Oh, thank you for introducing our softwares as well.
No, that's my pleasure.
Okay, so shall we get started?
Absolutely. Let's go for it. I hope everyone out there enjoys.
Okay, so just before begin, let me briefly introduce about Dr. Grishan, and then we can move on to our lectures. Okay, he completed a Bachelor of Dental Surgery at the University of Birmingham in 2001, followed by postgraduate studies in surgery. In 2002, Dr. Grishan served as an associate clinician in West London in gaining valuable experiences in the field. And you can find so many professional and academic experiences here. It's really amazing that he started his own business in north of London just 2 years later the graduation. And he became a trainer in Sirona, UK in 2006. I think he started digital dentistry faster than anyone else. And he was invited to be a lead practitioner at a prestigious London clinic in 2007. And after 5 years, he relaunched his practice as Skin and Smiles. and was awarded the Royal College Diploma in Implant Surgery in 2013. Also, we can find he created a dental laboratory and he established the company, which is Implant Solutions Direct Clinical Lead, and he is a global KOL for several companies. Wow, it was really, really long. Wow.
Yeah, well, that's how I keep busy.
Oh, I see. So are you a CEO?
Yeah, but it's just a title. I'm a CEO of two companies, but as I say, at the end of the day, I have work to do. I have patients to serve. I have customers to serve around the UK, and I'm a proud speaker as well for these various companies, and that takes me globally. So. To be honest, most of my roles are involved in digital or clinical dentistry or combination of the two. So I do enjoy teaching. I do enjoy trying to help others improve their workflows, and I collaborate with others as well, manufacturers, colleagues. It breaks up my day, and it makes every day a different day.
That's why you seem really busy and you are recording with me at 11 p.m. Yeah.
It's the nature of the work. Most of the companies that we deal with are outside of the UK, so we're often working with people in different time zones on a regular basis.
Um,
So if it means that I can help more people further afield, it's my pleasure.
and I saw your Instagram and it seems like you are really doing laboratory work, some
I
of the
do, yeah.
work.
Yeah. So
Wow.
I'm working in the clinic 3 days a week, and then I'm working in and out of the lab maybe, well, 2 days a week. I have non-clinical. So usually maybe a day, day and a half, I will give specifically to working in the laboratory. So I'm working on my own cases, some of my customers' cases. So I collaborate with the technicians that I work with that work for me in our business. And so it means that, you know, our lab is a little bit different in that it's owned by a clinician. So some of my customers specifically want to be able to work with another colleague. And so we kind of have a different spin on the work that comes through our lab because it's worked on by clinicians and technicians. That's maybe why we deal with a lot of implant surgeons because they know I've been in the implant field for 20 plus years already. So I can give them maybe a bit of an advantage on helping them to make their cases easier. And hopefully that comes through in the webinar as well, because I've given people a few different things to think about. Yeah.
We're very excited to attend your first webinar. So shall we really, really
Thank you.
begin, Doctor?
Let's go for it. Absolutely. Thank you,
Okay.
Jenny. Hello, everybody. My name is Dr. Gulshan Mergai. Thank you for joining me today in this Medit webinar. It's entitled A Dental Implant Journey with Medit, a case from planning to completion. During this webinar, I hope to share with you some of the workflows that I use in my practice on a daily basis, and hopefully it will make your use of Medit products easier, predictable, and also more profitable. So let's get into it, and let me tell you a little bit about myself. I qualified in 2001 from the University of Birmingham with my undergraduate degree. I've been placing implants, dental implants, for 22 years. I've been involved in scanning and digital design and CAD/CAM for 21 years. I've owned this practice for almost 22 years now. And I also own a commercial dental laboratory that's in its 10th year and a digital dentistry supply shop as well that's in its 6th year. So I'm really engrossed in my digital dentistry. I enjoy it, I speak about it globally, and I hope my content here is useful for you. So the disclosure that I've got to make is that, as I've said, I am a reseller. I have a supply shop. I have a little bit of a biased opinion. I'm also a global key opinion leader for the 5 companies that you can see listed on your screen, and some of their products will be seen here within this webinar. However, as a practitioner, I can pick and choose whatever I'd like to use in my practice. Let's take you through this patient journey. This is a patient whose name is Aladdin. He is a medical doctor and he's given permission for me to share the details of his treatment with you for the purpose of learning. He came to me in my practice in September 2020 as a new client. At that time, he had a crown on his lower left first molar, which was present for several years and had no problems at all. In August 22, almost 2 years after joining the practice, he came and saw me to say that the crown on that lower left first molar had come loose. And when we saw him in the practice, we saw that the core of the crown had failed. And as a result, we did a same-day crown for him. And I will be sharing that with you and how I did that with the Medit scanner shortly. January 2024, he arrived at the practice having seen an emergency dentist elsewhere over the weekend. He had pain on his lower left-hand side, and the emergency dentist that he saw suggested that he may have had a fractured tooth that needed to be removed. He only trusted us to do that treatment for him, so then he came to see me in January 2024, and a surgical extraction was provided as a result of a confirmed root fracture. Later that year, February 24, we did guided bone regeneration in that area, and it was done with a synthetic graft, and I'll take you through that as well. May 24, CT scan, surgical guide preparation, and we planned our pilot guided surgery for that site. And then in September 24, we restored that. And I'm going to take you through now how I've used Medit and other products in order to take my patient through this journey and give him a predictable end result. So this is Aladdin in August 2022. He attended the practice with saying that he had his crown that had come off, and you can see over here clearly evidence of micro leakage. This was an old porcelain bonded crown, never gave him a problem before. You can see in the middle there that the core material was silver cermet. So those that don't know, that's a mixture of a glass ionomer and a mercury amalgam type of material, so adhesive and metallic at the same time. On the right-hand side, you can see another view of the same tooth, which I think you might agree was in a little bit of a mess. Patient had no pain, no symptoms of any sort, just the crown had failed. So taking you forwards, you might recognize that sound. That's the sound of my Medit scanner working. What I did for Aladdin was we saw him on that appointment when he presented and removed the remnants of the metallic core, and we placed an adhesive glass ionomer core. We let that set in place. Now, we don't normally do this. I don't normally place a separate core under a crown of this sort in a non-vital tooth, but here, because so much tooth material was missing and the tooth had, let's say, a guarded prognosis, I thought, let's take this in stages, and that's what we did. So on the top image, you can see the core in place and tooth preparation has been completed. A shoulder margin has been placed around about 0.5 millimeter subgingival, and that is my scan with my i700 wireless of the working jaw. That's a quadrant scan. The bottom right-hand side here, you can see the opposing scan along with the working jaw, and you can see the amount of space that has been left. Obviously, there's some evidence still of the micro leakage, but everything that's left there is solid tooth and a solid core material. In the middle here, you can see the workflow. We did upper, lower bite registration in our stage management. And also you can see that I've used the trimming tools here in order to get a tidy set of scan data. And you can see there highlighted, I've used the export tool in Medit Link to send that data out. I sent it across to my Exocad chairside CAD software, and you can see that same data right here where I've loaded it in. You can see the original scan data. On the right-hand side here, you can see my proposed crown design. So I designed this crown whilst Aladdin was sat next to me. And we tried to get our patients involved in their dental journey, in the digital dentistry journey. And most of them were really keen to see what's going on with the technology that we can use. Here is the occlusal view. And what we did was in a single visit, we prepped, designed, milled, and placed that restoration for him. That was a feldspathic restoration. And yeah, he was very happy to get the function back on that tooth. That was a single visit. Here is how I do these single visits. So let me take you through this short video that was prepared between myself and my colleagues at Exocad. That's me preparing a tooth, an upper left first molar for a different patient, but I'm sharing this because it's similar in that here I'm using my Medit scanner to scan the quadrant, and that's the lower left quadrant because in this case, Paul had upper and lower molars, first molars prepared and had immediate crowns done in a single visit. Over here, you can see the design process, again, using Exocad's chairside CAD. The data is all acquired with my Medit scanner. This is obviously speeded up, but typically it'll take me 8 to 10 minutes to design a single crown. Obviously here a little bit longer because it is a pair of crowns, and you can see how we can use that software to go ahead and do a straightforward design. The next stage here is in-CAD nesting. That's using our chosen material. In this case, it's a hybrid ceramic material that we use, and you can see it's polychromatic. You can see the layers of the different shades of that material. And we're getting that ready to be able to be sent to our milling machine so that we can mill that chair side. This is exactly what we did for Aladdin, but in his case, it was a single tooth and not a pair. Here you'll see an example of production. You can see the little video running there. That's us using a different milling machine, VHF N4 machine, where we can mill multiple restorations in a single visit. You may also choose to use a 3D printer to print restorations. In this case, we're milling. Over here now you can see the fitting process where I've already had my colleagues etch the fit surface of the restoration that's come out of the milling machine. So we etch and silinate. We're using a dual cured resin bonding system to go ahead and place that restoration, full ceramic restoration. And that's being seated with an ultrasonic seating device and then light cured. Let's go forwards. So that was Aladdin's single visit restoration of his lower left molar, and that was done in 2022. Now, he came to see me in 2024. As I said, he had seen a emergency dentist prior to coming to see me. He'd emailed me that weekend and said, look, I've been to see someone. I was in a lot of pain. I couldn't reach you, and I've been told I might need an extraction. So just to put the story out there, let me show you how he presented in 2020. This is when he had his bonded crown in place, and you can see there the metallic core. That was that silver ceramic core that was extended into the top third, the coronal third of the root canals. No evidence of periapical bone loss, no problem at all with that tooth. On the right-hand side there is how he presented in January 2024. And what you can see there is a radiolucent crown. So that's that feldspathic crown that I made for him and placed a few years before. So that's radiolucent. We can see the core material underneath. That's now glass ionomer. And you can see a couple of things going on. Firstly, there is a furcation fracture going on there. And also on the mesial root, you can see an area of bone loss, probably due to either the fracture or infection or combination of the two. In the lower part of the screen there, you can see the different classifications of root fracture, whether they go through the coronal and into the root dentine or further. Those various classifications will help you decide whether or not you can actually do something with that tooth to restore it. In this case, we certainly chose to go ahead and remove it for Aladdin. So a treatment plan was discussed. We went through his options. We knew pretty much straight away that the tooth needed to be removed, and he didn't feel like going around without a tooth. He wanted to consider replacement. And in our practice, we will always discuss what are the provisions for replacing a tooth prior to removing it. And they are typically on removal of the tooth. You can have a gap, you can have a removable partial denture, you can have a bridge if the adjacent teeth are suitable, or you may have a dental implant. Now, in Aladdin's case, he'd had dental implant treatment with me before. It was highly successful, and he said, okay, let's do that. So I said to him, yeah, no problem, but this will be different to the last one because this will require two-stage surgery. And I explained to him that we would require to replace some of the missing bone that had been affected by his infection and the removal of such a large tooth. And then we'd be able to create some bone to go ahead and place a dental implant. So let me go through that with you. So it starts off with a precise surgical extraction in 2024 on that same visit when he attended in pain. Having seen the emergency dentist elsewhere, I confirmed the diagnosis. He said, let's do this now. We sectioned the tooth, removed it carefully, and were able to preserve as much bone as possible. So then going forward in February 2024, we'd given him 4 weeks of healing time, let the soft tissue close over, and we did a graft process with a synthetic material, in this case, a product called Powerbone Dental Putty. What's important to note there, is that prior to doing that, we opened up the surgical site and we used this instrument, a degranulation burr. So this is a diamond coated, very coarse diamond coated burr that we use to degranulate the site and ensure there are no soft tissue remnants. We've got good, clean, bleeding bone. And then we go ahead and inject the graft material into the site. This is the X-ray immediately post-op, and you can see down the middle in the interradicular space where we have some retained native bone, we have about 11 millimeters of height. So I was pretty happy with that, and we sent him away to heal. Now, after healing, 3 or 4 months of healing, we saw Aladdin, everything was pretty straightforward with regards to the grafting. Over here, you can see we have gone ahead and cloned his original scan data. So that's me highlighting the clone tool that's available in Medit Link. Now, whether you've got an i500, 600, 700 wireless or a 900, you can all use these tools. So this clone tool allowed me to clone his previous scan from when he had had his restoration on his lower left 6 natural tooth. I then replaced the lower jaw scan, and you can see here in the bottom the healing of the surgical site having been grafted. And over here, you might have seen me rotating that for you so you can see from all different sides. So we then took this data, again, quadrant data, upper and lower left-hand side, and we used that for our implant planning. So we scanned Aladdin at that stage, at that same appointment. This is actually Paul and not Aladdin being scanned in my CT scanner. And then we used software from Exocad called Exoplan, and we used that to go ahead and plan his lower left 6 replacement dental implant. And that's with me on the lower right-hand side doing my planning. This is actually Aladdin's report. This is something that comes out of the software. This way we can see in cross sections what it would look like. We propose the tooth in 3D, and I'll show you how we do that in a moment. And we have a report that tells us what implant to place, what angulation it will finish up at, and such like. So this is the surgical guide design. In Aladdin's case, we opted for a surgical guide that was pilot driven, so pilot drill. In the lower left-hand side, you can see the most important element here is that this is a restoratively guided implant plan. So this helps us to ensure that wherever we place the implant, we can actually restore it in a way that's suitable to restore his function, because most people don't need a screw in their head. What they really want, what they desire, is to get their function and their aesthetics back. In this case, it just so happens to be with a dental implant. So we want to put it in the correct 3-dimensional position in order to be able to restore it in a predictable way. So here we are. Here is the surgical day. This is the second stage of his 2-stage treatment plan. And this is the implant placement. So guided bone regeneration was done. We've grown some bone. You can see my surgical toys there. You can see the pilot drill guide in place, the implant of choice. And here, most importantly, that's the end result. So you can see on the X-ray, we have healed bone. You can see that's actually Aladdin's X-ray. In the mesial root space, we've got some increased density, and you can't tell from that 2-dimensional image, but that implant is tilted lingually as per the plan. Let's take it a step forwards, and let me now show you what we did with the restorative element of Aladdin's plan. So this is me showing you a few different things now, and hopefully making you guys think outside of the box and not just the standard screw retained crown. I would like to show you some different things, and let me show you where we went with this journey. So just to start with, this is Aladdin with his full ceramic crown in place, having attended in pain, and we agreed that he had a root fracture. In the middle at the top there, you can see the result post-extraction. And on the top right-hand side, this is post-graft surgery. So this is synthetic graft material, and that was left for a good 3 to 4 months of healing. Bottom left-hand side, you can see the implant, which I just showed you. We placed the implant that's immediately post-surgery. And in the middle at the bottom, we have a restored implant. But we also have another restoration here. These are both the same case. Aladdin, being a medical doctor and a lecturer himself, allowed me to use his case as a test case, because look, I said to him, yours is an ideal case for me to teach people with. Can we do a few different things for you? And he said, what do you mean? So I said, look, what I'm going to do is I'm going to make 2 crowns from the same set of data. You'll only need to attend for 2 appointments, one for the scan, one for the fit, but I'd like to do 2 different workflows, and I'm going to share those with you today. So the middle here is a workflow where we've created a classic screw retained crown on a molar, very straightforward and easy and predictable to place. And I'll take you through the workflow in a moment. On the bottom right-hand side, though, that's something a little bit more special. That is a custom abutment with a crown on top of that. And both are zirconia crowns. And let me show you how we did this. So here we worked with our partners at ELOS along with Medit. So on the left-hand side there, you can see his surgical site. And those of you that are savvy are noticing that on the buccal aspect, we have lost some bone volume. And that's why that implant had to be tilted to the buccal. So when we did our planning, we could see that, and we tilted it to the buccal so that we could retain some bone. And this is absolutely normal with the type of infection and the furcation, root fracture and the trauma that he had. In the middle there, you can see the scan body in place, and from a different angle there, this is the ELOS Accurate scan body, which I'll tell you some more about shortly. Over here, let's look at what we did with our Medit scanner. So again, we did a clone. So this is a clone of the original data. This is from our planning, and we're using the same data in our restorative. But what we're doing, if you look carefully down here, you can see that I've sectioned out the section of data that would have been changed during the implant surgery. So that's the clone data. I've trimmed it. Once I've trimmed it, I've used a lock tool. And once I've locked it, I've been able to scan in just what's changed. So that gives me speed, predictability. As we know in dentistry, time is money. So it's really, really important to be efficient, and the Medit tools allow me to do that. Bottom right-hand side, you can see the scan body in the Medit scan data. And just here to remind me to tell you guys, I've used the lock tool in order to ensure that I don't have overlapping data. So this is a pretty straightforward workflow for me. Let me tell you how I take it forward. Now, I designed this myself. This is using, again, chairside CAD, so one of XCAD's product, the same software that I used a few years before to design the restoration on the tooth that was originally in that position. So what I'm highlighting here is that if you look back there, we have a round tissue profile. That was where the healing abutment was. That was turned into an elliptical profile here with digital tissue conditioning using exocad software. Over on the right-hand side, you can see the Medit scan data, the scan body, and here is the same scan body data. Now, moving forward, here's what we did first. We proposed the design of a crown, which you can see in the main screen down here, and superimposed behind that, you can see the design of a custom abutment, a titanium custom abutment. So I'm going to show you what we did with that. Over here, different views of the crown, the buccal, excuse me, the buccal view, the lingual view. And just to show you why we're doing this custom abutment, I've shown you this view where you can see the implant analog and the angle, the distally inclined angle that is at. So that's where the implant's sitting in bone. You can see the angle matches that, it's parallel to that of the lower left second molar. But what we wanted to do was to upright that implant and go ahead and give us a well-restored implant, but also one where the porcelain is well supported as well. So hence the custom abutment. This kind of highlights it. Over here, we can see an array of different holders for the ELOS titanium blank. It's called a PMB, a pre-milled blank. Comes for different machines. In our case, we're using VHF machines, and here it is in its kit. We have a few different milling machines in our practice and our in-house lab. So I'm just showing you the different array of materials there. The ELOS Accurate workflow is a validated one. So whether you're watching this in the US and you need to ensure that it's FDA approved, I can assure you that it is. Or if you're in Europe, you're looking for MDR registration, that's also there, along with the library that allows you to restore all kinds of different makes and models of implants with the ELOS Accurate workflow. Over here, some of my machines, the N4, Z4, and the R5, all from the VHF manufacturers in Germany. We've got one of each of those machines, and so we can mill titanium blanks to our heart's content. Over here is actually Aladdin's result. This is a 5-axis mill of his custom titanium abutment, which I was able to do in-house. And here is some of the results. Now, when I say some of the results, this is not just the custom abutment, which is right here, and it's fitting, but also we have a titanium base. Now, all of these restorations, these 2 different restorations were made from the same set of scan data, that one set of scan data, and I basically took the workflow through twice. Once designing a custom abutment, once designing a screw-retained restoration. Both with zirconia crowns, same zirconia, same material, and you can see the different images that my colleague has provided me here. This is my lab technician that's done all of the finishing of these materials for me, and you can see the end result. Taking you forward, let me just show you the not the scan body, the ELOS Accurate titanium base. This is a little bit different. It's called a hybrid base, and what it allows you to do is not just have an occlusal screw channel, but also because we have a cutout, it allows a certain degree of angulation, and as it says there, up to 28 degrees of angulation for an angled screw channel. As long as you're able to mill a restoration that can cut the angles, you can go ahead and correct steep angles up to 28 degrees. So we took that forward and we actually made a model as well from the same set of data. Same set of Medit data allowed us to design the restoration, allowed us to produce this model. Why did we do this? I don't normally produce models. Well, in Aladdin's case, as I said, he had a root fracture and he'd had a history of breaking teeth in a similar way. So what I wanted to do was ensure that we had tested in every which way possible the restoration before we went and fitted it. And in this type of restoration, we have mounted it on a special type of 3D printed model. As you can see here, it's got an articulator built in, lots of different options for this type of articulator, and it allows us to test in lateral excursions, protrusive excursions, to ensure that we have maintained the occlusal scheme of choice and hopefully reduce the risk of him overloading his implant and causing a failure. Going forwards, let's show you what happened clinically. So initially here, I'm fitting my custom abutment. So this is what you saw in the earlier slides that I have designed and milled myself. I've placed it. You can see under local anesthetic, the tissues are blanched and white there. Also, you can see here that we have a horizontal platform. That's where our finish margin of our zirconia crown will sit. And that's very important to note because this here is going to be a cemented restoration. And I know that's frowned upon, but it actually is something that we've been doing many years very successfully. As long as you can have control of where the cement is going to go, and we have in this case, then it's absolutely safe to go ahead and place a cemented restoration. But it's all about control. And that's what digital dentistry brings us. If you can scan well, get a system and a workflow in place where you can either work with your technician or design a restoration yourself where you have control of the soft tissue profile, as we have here. We created that soft tissue profile from the round circle of the healing abutment into this elliptical shape of the custom abutment, and that allowed us to do this, which is to seat his definitive zirconia crown. What you're seeing there is the seated crown and the lingual excess cement. This is with the lingual cleaned up. This is on the buccal side, and this is after the cleanup. And this image here is the occlusal scheme. You can see a little bit of the metal there. It's just been fitted. So this is an image immediately after fit. So I'm not worried about that. That tissue will mature and heal and likely cover it up. But it's a lower first molar, can't be seen, and it's not really in the aesthetic zone. I was really happy with that end result. The most important thing for you guys to see here and why I'm sharing it is that this is a cemented restoration on custom abutment that's been placed in a predictable way. The cement of choice is Premier implant cement, so it's a recoverable restoration. I've got an instrument that I can use to easily remove that crown if needs be, so we don't have a problem with recoverability. Going forwards, as I said to you earlier, we also made a second restoration for Aladdin. So this is exactly the same surgical site on the same day, same appointment, local anesthetic in place. And what I did was I placed a restoration that was classic screw retained restoration with a screw coming through the mid occlusal. Yes, it's more towards the lingual, but you can see the reason why. That's because we have some buccal bone loss going on there. That was predictable. But on this view, you can see it's quite a reasonable position for that screw access hole. And this is the device underneath that is supporting it. So this is the ELOS Dental, ELOS Accurate titanium base, the hybrid base. And it allowed us to make a angle screw channel within this crown to correct the angulation. You saw earlier that with the custom abutment, we corrected it in the design. Over here, we're using accessibility of this cutout in the titanium base to give us the availability of an angled screw channel. So we go ahead and place that. Over here, you're seeing the final result. On the left-hand side, we have the post-op X-ray of the restoration, which is seated on a custom abutment. How can I tell? How can you tell? Well, look how wide the emergence profile is compared to this one, where we have a narrow neck in the middle. That narrow neck is where we have the titanium base supporting the restoration, which then rises up. And it gives us a different, not a bad emergence profile, but a different emergence profile. During this appointment, Aladdin was asked, which one do you prefer? And he said, well, they look and feel the same to me. Of course they feel the same. He's anesthetized, so he can't tell. He said, I'll leave the choice to you. You decide which one is best to fit. And I said, Aladdin, listen, I know you're a busy man. I know you don't always have time to floss. My hygienist has told me that. So I'm going to suggest that we go with the custom abutment because it gives you a wider emergence profile, less chance of a food trap. And given that you have a history of breaking teeth, I'd rather have a crown that's supported with a huge lump of titanium underneath. He totally agreed, and we fitted that restoration for him. That is the end of the data, the information that I'd like to share with you. Thank you very much for listening to this webinar. If you do have any questions for me about these workflows, about what we've done, how we've done it, and how I used my Medit scanner to achieve these results, how we collected the data, please feel free to get in touch with me. You can see my contact details are right there. Thank you very much for listening. My name is Dr. Gulshan Mergai.
Okay, thank you for preparing such a great lecture. So let's move on to Q&A sessions.
Yeah, let's go for it.
Okay, we have 4 questions in total. So I'll start with the first one. So question number 1, what do you think is the key part when planning an implant treatment?
Thank you. Very good question. We get this a lot, and the answer is very, very simple. If I'm planning an implant treatment, the first thing I need to know is the surgeon, so if it's a case for somebody else, I'm going to know, well, do you want to do this as a guided surgery? And if they do, a lot of people haven't done that before. And, it's there's 2 elements to it. One is let's make it restoratively guided. What that means is no patient, and I said this in the webinar as well, no patient wants a screw in their head. What a patient wants is a fixed restoration. And by offering it as a implant type of restoration, what's happening is that essentially, we're giving them a fixed restoration. Now, I think it's more important to have that planning, that implant planning treatment done restoratively guided. That means you plan where the tooth is going to go and you say, yeah, I like that position. And then you work backwards from there. That's really the process of planning an implant well, in my case. And that's done easily with Medit because as long as you can pick up a really good, clear intraoral scan, then there are many softwares out there that you can either work with by yourself or with your lab to plan an implant treatment. So I hope that's a good enough answer, Jenny.
I think you said top-down treatment planning is very important.
Yeah, that's exactly what it is. There's a different
Yeah.
terminology for the same thing, top down, restoratively guided, or 3D implant planning. 3D implant planning used to be all to do with what bone is available, let's use that. But patients don't care what bone is available. Patients care about what the end result is.
Yeah.
So that's why I think restoratively guided or top down, that's the way to go. So plan where the tooth is going to be, then reverse engineer that to where the implant would ideally be. And that then gives you an idea as to how much leeway you have to use different treatment modalities.
Yeah, thank you for answering about question number 1.
Thank you.
Okay, and let's move on to question number 2.
Mhm.
Once I took off the healing abutment, I was unable to scan the transgingival zone as it was too deep. Any tips?
All right, thank you very much, Jenny, for that second question. Great question, and not one that I've had before, but very useful. So, as a clinical technician, let's say, as a clinician and a technician, I can tell you that the position of the head of the implant will be gained by the scan body or the scan marker. So, as far as the transgingival zone, really what you need to be able to show using your Medit scanner is the top 2 millimeters. So let's say the implant is 4, 5, 6 millimeters down. That's nothing to worry about as long as you can try and do your best to capture the top 2 millimeters of the transgingival zone. I hope that answers the question, Jenny.
Okay, that's a clinical tip for everyone.
Mhm.
Okay, next question. Question
Thank
number
you.
3. How can you retract the margin for implant abutment finish line?
Good question, especially in the light of Medit and what you can do with Medit, because to be honest, it's not something that I need to do often. But if I gave you a clinical scenario, let's say a patient had a implant crown, the crown came off and they've lost it, and the abutment is still there. And let's say the gum has collapsed around it, so you can't see the finish line.
Yeah.
Okay. Now, with Medit, what you can do is you can remove that abutment from the mouth. You can place it in maybe some putty or some wax, and you can scan it outside of the mouth. You can then record that into the Medit library. So locally, you can record that data in the Medit library. You then go ahead and place it back in the mouth, and you can use something called AI abutment matching. So AI, obviously artificial intelligence, abutment matching, what that will do is when it goes back in the mouth, because you've stored that data in the library, the Medit scan software, so within Medit Link, it will allow you to capture that within your normal scan. And then you can use a couple of different tricks to either automatically or manually match that. So what happens is at the end of the scan, you can then see the margin, which is subgingival, without needing to use retraction cord, and it is digitally accurate. So that is called AI abutment matching, and it's pretty much only found in Medit. So another great reason to use Medit to scan your implants when you have some kind of complexity like that. So there's actually no reason to use a retraction cord or anything like that and put patient through discomfort when you can have it absolutely digitally accurate using this technique.
Yeah, 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 1 month matching.
I thought
Okay,
you would like that one.
yeah. Okay,
Great.
question number 4. How do
Mhm,
you manage the implant path when it's bad in a long bridge case?
mhm. Thank you very much for that number 4 question, Jenny. So this is a complex case that you've kind of described. So let's take the case of a full arch bridge. So maybe all on 4, all on 6 type of restoration going around the arch. And you're mentioning that the difficulty here is that the path of insertion is different or difficult. My best suggestion in a case like that is that the practitioner that's doing the scan uses scan bodies around all of the implant fixtures, but they take those scan bodies of the fixture and not the abutment. So often, if the insertion path is complex or implants have been placed at maybe incorrect angles because of the fact that they didn't use guided surgery, then the solution or the biggest availability of solutions will be if they speak to their lab and say, listen, need your help here. I've put scan markers in, I've scanned the positions, and then what happens is you have custom abutments made in order to correct those angles. So that's one of the ways, Jenny, to go ahead and correct the path of insertion. So in this webinar, you saw that the implant that we restored was lingually tilted. And what we did is I proposed two different options. One was an angle screw channel in order to correct that angulation, and the second was a custom abutment. So, like you've asked in the question, if there was a bridge that had the same problem, it would be a similar solution. As long as the scan is of the implant and not of the abutment, then you give yourself more options in terms of angle screw channel design or in terms of custom abutment. Does that answer your question, Jenny?
Yeah, yeah, very clear. Thank you for sharing your tips. Okay, thank you for answering all the questions today. Thank you for being a doctor until the late night. How was your first webinar?
That's okay. It was really fun. I mean, I've got to admit, I did several tests and several takes getting things set up. We used a bunch of different cameras. We used a bunch of different mics. And as Jenny knows, there were problems with the sound recording and this and that. But I persevered, and I hope that for everyone that's taken the time to watch the webinar, listen to the Q&A, and also your intro. Thank you for your very kind intro, Jenny. I hope it was of use, and I look forward to doing some more of these for you guys. So let us know what kind of topics you'd like to see, whether it's something clinical or technical, and maybe myself and Jenny can organize something more for you.
Okay, thank you for being here, doctor. Hope to see you next time. Okay, bye
Thank
bye.
you. Bye bye.